Good afternoon. Hope you're having a great day. My name is Nicholas Krapser. We hope you enjoyed the following 60-minute webinar from Margaret O'Hara and I on trends in addiction assessments, methods, and usages. Both Margaret and I are nationally board-certified mental health counselors and have a combined total of over 4 decades in the helping profession. The purpose of this 60-minute webinar is to give you the basics and history of addiction assessments, as well as to help clarify and define some commonly used terms, phrases, and coding. The objective, by the end of this webinar, is not that you become experts in the field of addiction counseling and assessments, but instead to get a basic knowledge and history of assessments and trends in the field. I will be your webinar host for the next 60 minutes, and Margaret O'Hara will be narrating the PowerPoint that we use. There will be some videos along the way and a few interjections from me, and at the end there will be a quiz for the purposes of review. If you're having a difficult time hearing the narrated PowerPoint, just simply turn up your volume. This is a recorded webinar, which is uploaded to YouTube. So if you have any questions or comments, please feel free to comment or ask questions in the section below. So without any further ado, let's get started.
The American Counseling Association defines assessment as the process of collecting in-depth information about a person in order to develop a comprehensive plan that will guide the collaborative counseling and service provision process. Assessment is an ongoing process, helps clarify the diagnostic picture, determines severity of use, and guides treatment interventions. Drummond and Jones differentiate informal from formal assessment. In informal assessment, there's no proven reliability and validity. It consists of unstructured interviews, clinician-created checklists, and anecdotal information. In formal assessment, instruments are standardized. That is, there are structured materials, uniform administration procedures, and consistent methods for scoring and interpretation. These include structured interviews, standardized tests and inventories, and rating scales. We see here on this slide a list of topics that are typically covered in unstructured and semi-structured interviews. I'll give you a moment to peruse the list. And then these topics are typically covered in more formal assessments. The University of Washington maintains a database of tests that are related to alcohol and substance use that I would refer you to. The Substance Abuse and Mental Health Services Administration, SAMHSA, under the U.S. Department of Health and Human Services, puts out different publications. Among them is the Technical Assistance Publication Series, or TAP. TAP 21 covers the competencies for addiction counseling and includes 12 core functions. You see the fourth one listed there as assessment. The same organizations put out treatment improvement protocols. TIP 42 covers substance abuse treatment for persons with co-occurring disorders. This is a list of the 12 steps in the assessment process when you are assessing someone who has both substance use disorders and possibly co-occurring disorders. So the first step is to engage the client. Next, to identify and contact collateral, such as family, friends, other providers, to gather additional information. Next, we screen for and detect co-occurring disorders, determine locus of responsibility, level of care, diagnosis, disability and functional impairment, strengths and supports, cultural and linguistic needs and supports, problem domains, and we also determine both stage of change that the client is at and plan treatment accordingly. So our assessment methods include a general diagnostic intake interview, screening tools, including symptom inventories, the more in-depth biopsychosocial assessment, mental status exams, assessments for toxicity, intoxication, and withdrawal, and level of care determinations. There are many screening and assessment tools. Here is a list of some of the more popular ones. We have the DAST, SASI-3, craft, 5 Ps, the audit, the NIDA quick screen, and the NIDA modified assist. The audit is a 10-item screening tool developed by the World Health Organization. It has both clinician-administered version and a self-report version, and includes a standard drink chart. A score of 8 or more indicates hazardous or harmful alcohol use. This is validated across genders and racial ethnic groups and is used in primary care settings. The NIDA Quick Screen questions alcohol, tobacco, prescription drugs for non-medical reasons, and illegal drug use in the past year. If the patient indicates no for all of the responses, the screening is complete. If they say yes for drinking, they're further screened as an at-risk drinker. If they screen yes for tobacco, smoking cessation is guided. And if they say yes to illegal or prescription drug use for non-medical reasons, then you proceed with the NIDA Modified Assist test. Considerations when evaluating tests to use would be reliability and validity evidence, the normative sample and intended population, the type of setting in which it was developed and is standardized, its intended purpose and other suggested uses, as well as practical considerations such as cost and ease of administration. So in speaking about trends in alcohol use assessment, we would need to go back in time. So we're going way back to ancient Greece, where there was the symposium. With this, Greek hosts served their exclusively male guests a mixture of wine and water in a decorated vessel called a crater, and assessed the following reactions to the number of bowls they drank. The first 3 were considered the choice of the individual. So the first bowl was for health, the second for pleasure, and the third induced sleep. After that, it was said that the individual no longer had control. So the 4th bowl belonged to violence, the 5th to uproar, the 6th to drunken revel, the 7th to black eyes, the 8th belonged to the police, the 9th led to biliousness, and the 10th led to madness and the hurling of furniture. So biliousness is defined as irritability, crankiness, and refers to the secretion from bile. In 1849, Swedish physician Magnus Huss coined the term alcoholism. Before that, terms such as drunkenness, inebriety, and intemperance were used.
So we'll just take a quick pause there with what Margaret is saying, and we'll look at this website here on the history of addiction, treatment. So there's, first of all, a summary, and then it goes from the 1750s to the 1800s. And then there's a section on the 1800s. And then a section 1900s to 1950. 1950 to 2000, and 2000 to present, with a list of sources at the bottom too, in case you wanted to do some additional research. This can be found at www.recovery.org/topics/history of addiction treatment. So we'll go back and listen to Margaret a little bit more.
In talking about assessment relating to addiction, we would want to think of theories of addiction and how these influenced the assessment taking place under the model. So we begin with the personal responsibility model based on moral theory, that use was just an indication of poor decision making, and that it was a violation of ethical, moral, and religious principles. It's based on Puritan beliefs in the 18th and 19th century. There was cultural stigma. According to Miller, Forsymes, and Zwiebin, the remedies suggested by this model included legislation, education, repentance, punishment, and social sanctions. In this model, genetics, neuroscience, and environment were not considered. The agent models pointed more to the substances themselves as being the cause, being the problem. And so we go back to the temperance movement, which led eventually to prohibition, 1919 to 1933, where it was illegal to manufacture, sell, and transport or import liquor. This is analogous to the 20th century war on drugs declared by Nixon. In retrospect, many believe that this was primarily targeted at anti-war activists and ethnic minorities. In the 1970s, the Drug Enforcement Agency and other agencies were established, and the drug war continued in the 1980s with the crack epidemic. We see during this time massive increases in long-term incarceration for low-level, nonviolent offenders. To date, over $1 trillion has been spent with little positive effect on the.
So we'll just pause there and add to what Margaret was saying. We're still dealing with the effects of this policy with mandatory minimum sentencing, jail and prison overcrowding, overrepresentation of people of color in the justice system, and unfair laws targeting people of color, such as penalties for possession of crack cocaine, which are more than 10 times harsher, or could be up to more than 10 times harsher than possession of cocaine. The Obama administration made great strides to correct and reverse many of those sentenced under these guidelines, but much, much more still needs to be done. In fact, let's take a look at a quick graph here, and keep in mind that this is just in Oregon. So on this demographic, you see substance abuse in DOC. I want to draw your attention here to the 57% that identifies having a severe addiction. Moderate problem, 16%. So you can see the vast majority of this wheel is either identified as severe addiction or moderate problem. And then one here with mental health demographics within DOC. And notice we have the highest need, severe need, moderate need, and benefit from treatment as being just about half of that wheel. So about 50% of those folks in DOC with identified mental health disorders of some kind. So that was just in Oregon. Margaret mentioned that over $1 trillion has been spent with little to no effect on drugs. Each year, more and more people are incarcerated in the United States being the #1 incarcerator in the world, which amounts to about an $80 billion per year industry. So once again, just speaking about Oregon here, on July 18th, 2017, Governor Kate Brown signed into law, making simple and personal possession of most drugs no longer a felony, but instead a misdemeanor. Oregon joined a handful of other states in doing so. Surprisingly enough, some of the biggest supporters of the bill were the Association of Sheriffs and the Association of Police Chiefs. We're starting to see the effect of this bill going into effect with less people going to prison and more people getting help. If you're interested, here is a article from U.S. News and World Report talking about what I just spoke about with Oregon making drug possession a misdemeanor. This article is referenced in the reference section at the very end of this webinar. So you're more than welcome to write that down and look it up on your own. Let's go back and hear some more from Margaret.
The drug war. Next, the dispositional model, and this includes disease theory and the medical model. So this, in 1935, Alcoholics Anonymous was founded, and the idea that alcoholics suffer from an illness. In 1946, Jelinek came up with specific signs and symptoms, and he generated 5 types of drinking behaviors. In 1956, the American Medical Association added alcoholism as a medical condition, which led to scientific studies. In this model, we see that it was considered brain disease with neurotransmitter imbalance, and it was progressive. The belladonna treatment was a famous treatment taking place at Charles B. Towns Hospital in collaboration with Teddy Roosevelt's physician. And this was a very costly treatment because it was a concoction, a remedy, and it was for the wealthy. The stay at Charles B. Towns Hospital was upwards of $350 a day, the equivalent of $5,600 a day today. Here we see Hazelden Betty Ford has put together a representation of the Jelinek curve, and it shows the progression from progression of the disorder in the crucial phase through the chronic phase, and then the turnaround through rehabilitation. So we see this representation could be used to show individuals where they were at in the process, assess where they were, and then to act accordingly. In the psychodynamic model, it was believed that substance abusers were self-medicating and that it was a symptom of underlying psychological problems, that it was a maladaptive psychological coping strategy, and that once the internal conflicts were resolved, the substance abuse would be unnecessary. During this time, we saw the debate of nature versus nurture, or genetics versus environment. This is under the biological model. Here we see twin studies, adoption studies, and other heritability studies. Testing genetic theory, the idea that addictive use of drugs is based on individuals' genetic heritage, that there are genetic predispositions for addictive behavior, and that this occurs on the molecular level. Again, with the behavioral model, we see a continued emphasis on the nature versus nurture debate. With classical conditioning, where we have the stimulus and response, or operant conditioning, where there was contingent reinforcement and punishment, as well as with Albert Bandura's social learning theory, where we see modeling, for example, by family, peers, and advertising, as well as drug expectancies. Also, the use of diverse conditioning falls under this model. For example, medications such as antabuse would be administered, which would cause the individual to be violently ill if they ingested alcohol. We started to see shifts in perspectives. There was evidence was lacking in the effectiveness of the drug war. We saw in the 1990s a meth epidemic, and then the formation of drug courts.
So just a quick pause there for a second. While Margaret is talking about the drug courts, back again to Oregon, the first drug court was established in Multnomah County in 1991. And as of 2015, more than 27 of Oregon's 36 counties have some type of specialty court, with the ability to completely vacate the crime, reduce the charge, or avoid prison sentence upon successfully completing drug court. I've had the privilege in my career to work with drug court, veterans court, mental health court, and in Washington State worked with family treatment court, where individuals opted into the program to either remain with their children or gain custody of their children once again. So let's listen to Margaret for a few more lines here, and then we'll have a video to play.
Law enforcement began to work with recovery advocates who organized and gave voice to the need for change. Policy started to shift to the need for an approach that was more related to healthcare, and stigma begins to be addressed.
So let's take a look at a video. This one's called The War on Drugs, or How the War on Drugs Betrayed America. And once again, all of the references for these are going to be found at the very end of this webinar.
This episode is brought to you by AJ Plus. In a 1971 speech to Congress, President Richard Nixon called drug abuse America's public enemy #1. In the same speech, he declared war on drug addiction, and since then, the war on drugs has been a controversial policy issue for the United States. After 4 decades, we want to know, did the war on drugs work? Well, in the last 44 years, Nixon's connection between crime and drugs has had far-reaching consequences, particularly in terms of race. Human Rights Watch has reported that in the 70s, African Americans in the US were already being overrepresented in drug arrests, with twice as many arrests as Caucasians. But since the war on drugs began, African Americans have been arrested for drug offenses at 5 times the rate of white offenders, and yet on average, Caucasians commit more drug crimes. Part of the reason for this discrepancy has been attributed to unfair drug sentencing laws, specifically targeted toward minorities and the poor. In 1986, President Ronald Reagan signed a bill that authorized the Anti-Drug Abuse Act. This enacted mandatory minimum sentences for convictions concerning a number of drugs, including 2 forms of cocaine. Crack cocaine, which was cheaper and more commonly used by the lower class, carried a mandatory minimum sentence of 5 years for 5 grams. For the more expensive powdered cocaine, one would need 500 grams for the same sentence. This 100-to-1 disparity, along with other similar drug laws, skyrocketed the number of minority drug arrests. Only in 2010 did President Barack Obama authorize a bill that lessened the gap in drug sentencing. The Drug Policy Alliance reports that annually, the U.S. spends more than $51 billion on the war on drugs, and in 2013 arrested 1.5 million people on nonviolent drug charges. In fact, some estimates place the total amount spent by the federal government on the war on drugs as high as $1 trillion. And yet, addiction rates have been unaffected, drug prices have dropped considerably, and the U.S. has the highest incarceration rates in the world. In 2010, more than half of all federally incarcerated prisoners were serving drug-related sentences. Even the CIA has been implicated in the trafficking of illegal drugs. If our own government can't avoid violating drug laws, how can we be expected to? With marijuana legalization slowly spreading across the US and the success of drug decriminalization in countries like Portugal and Uruguay, it is clear that the war on drugs has failed. The illegal drug trade is a complex and sometimes overwhelming system to understand. To learn what the whole story of an 8-ball of cocaine can look like, check out this video from AJ+.
Cocaine, it's a hell of a drug. It's also hella expensive. An 8-ball, an eighth of an ounce or 3.5 grams, costs around $250 in the US. But what's the real price of that little baggie?
There's a link to that video also down in the description. Thank you for watching Test Tube. Please subscribe. We appreciate your support.
So we'll go back to Margaret for a little bit more on this topic.
The sociocultural model emphasizes the influence of societal and cultural factors and notes that attitudes of alcohol drug use vary from culture to culture, that there is increased use in certain environments such as the military and college campuses, and that the media influence perceived norms. We see differences in risk factors by gender, race, ethnicity, age, socioeconomic status, sexual orientation, and gender identity. What's commonly referred to nowadays is the integrated model. The idea that substance use is a result of aspects of some or all of the previous models, that all of the models are true to greater or lesser degrees, and it's a developmental approach to recovery. Explanations that focus on single cause or a single model are too simplistic. We saw the first ever Surgeon General's report on alcohol, drugs, and health, and it reviewed what we know about substance misuse and how we can use that knowledge to address substance misuse and its related consequences.
So let's quickly take a look at that Surgeon General's report. It can be found at addiction.surgeongeneral.gov. Here is the page. So it starts out with Facing Addiction in America, has the executive summary and a couple other headings there. And notice the chapters and appendices off to the right-hand side under Get the Report. A good website to take a look at and give you some additional information. And this website is also in our reference section at the end of this presentation.
Miller, Forsymes, and Zwiebin refer to the integrative approach and being comprehensive and evidence-based, multidisciplinary, holistic, and collaborative. So these are some of the changes we've seen this decade. In 2002, the FDA approved epinephrine, a medication-assisted treatment for opioid addiction. In 2008, the Mental Health Parity and Addiction Equity Act was passed. This provided for equal treatment for mental health and substance abuse on par with treatment that was for physical ailments. In 2010, we saw the passing of the Affordable Care Act, where insurance offered through state insurance marketplaces needed to cover behavioral health, including substance abuse treatment. And then in 2016, the American Medical Association petitioned to drop pain as a vital sign in response to our current opioid crisis and national addiction epidemic. In substance abuse, the diagnostic classification systems include the Diagnostic and Statistical Manual of Mental Disorders, the current version being the 5th edition, the International Classification of Diseases in its 10th edition, and the American Society of Addiction Medicine.
So Margaret mentions the ASAM text, or the American Society of Addiction Medicine text. Here is the book right here. This is the 3rd edition. It makes a great accompaniment for the DSM-5 for anyone in the field of addiction counseling. In addition to explaining the criteria for substance use disorders, it also dives into co-occurring disorders and breaks down the dimensional analysis into each of the 6 domains: acute intoxication and or withdrawal potential, biological conditions and complications, emotional, behavioral, or cognitive conditions or complications, readiness to change, relapse, continued use, or continued problem potential, and recovery living environment. If you'd like to write all of these down, Margaret has a slide later in her PowerPoint coming up here soon that you can pause if you'd like to review or just jot it down. Here's a quick look at the Amazon page if you're looking to acquire this book. I'll give you just a moment to write that down. This one says $174.99, but there's some other ones on there cheaper. I'm highlighting the ISBN number if you'd like to pause it to write it down. All right, well, let's go back and listen to some more of this PowerPoint.
Also known as ASAM. The DSM has undergone many revisions. It was first introduced in 1952 by the American Psychiatric Association, where alcoholism and drug addiction were grouped with sociopathic personality disturbances. In the 2nd edition, in 1968, there was great influence by Jelinek, and there were subtypes of alcoholism included. In the 3rd edition, we saw a separation of alcohol abuse, which was considered minor usage, compared to dependence, which was more your moderate and severe levels. DSM-4 more clearly separated the criteria for abuse and dependence, defining over 100 substance-related disorders. And then there were quite a few changes with the DSM-5, our most current edition, where the multi-axial system was removed. This was a system where there were 5 levels of diagnosis considerations, including the GAF score, which was the Global Assessment of Functioning, where a client would be assigned a score. These have all been eliminated in the 5th edition. The abuse and dependence has been changed to a single diagnosis with severity categories, for example, mild, moderate, and severe. And behavioral addiction was added with the inclusion of gambling. Other changes include the elimination of polysubstance disorder, which was used in the past when someone suffered from 3 or more substance use disorders. Also, the criteria for assessing legal issues was dropped with the 5th edition, partly due to the fact that the sanctions across the globe vary so much for substance use disorders that it's not accurate to include that appraisal in the diagnostic process. So a measure that's used as a screening tool is On the APA website, it's the level 1 cross-cutting symptom measure. There's both an adult measure and then also for younger clients, there are other assessment measures. There are 11 criteria for substance use disorders, and you would be assessing in the prior 12 months, looking for a problematic pattern and significant impairment. So beginning with the client ingesting larger amounts during a longer period than intended. The second criteria is persistent desire or unsuccessful efforts to control use. The third is time spent to obtain, use, and recover from the effects of the substance. The fourth considers craving, strong desire or urge to use. The fifth assesses for failure to fulfill major role obligations at work, school, or home. We'll continue here on the next slide. The sixth criteria is use despite social and interpersonal problems. And then we see the assessment of social, occupational, and recreational activities reduced because of use. Use when physically hazardous, such as driving. And then the ninth criteria is use despite physical or psychological problems that are caused or exacerbated by use. And 10th is with tolerance, and 11th, assessing for withdrawal symptoms. The DSM-5 recognizes 10 classes of drugs. They are alcohol, caffeine, cannabis, hallucinogens, inhalants, opioids, sedative hypnotics and anxiolytics, stimulants, tobacco, and other or unknown substances. In the diagnostic coding, the clinician would include the name of the disorder and then the specific substance. It would include the severity rating. Mild would be 2 to 3 criteria. Moderate is 4 to 5 criteria. Severe is 6 or more criteria. And then any appropriate subtypes and specifiers, such as an early or sustained remission, in a controlled environment, such as one being in treatment or incarcerated, and on maintenance therapy, such as with use of medically assisted treatment. ASAM has 6 dimensions of their multidimensional assessment.
Here's that slide I was talking about a few minutes ago where Margaret is going to go back over the 6 dimensions of the multidimensional assessment. So feel free to pause this or write it down.
Each of these is assessed according to level of impairment. These include acute intoxication and withdrawal potential. The second is biomedical conditions and complications. Then we look at emotional, behavioral, or cognitive conditions and complications, the client's readiness to change, relapse, continued use, or continued problem potential, and then finally we assess the recovery, the living environment. So each of these are rated, and then those ratings are given consideration in terms of level of care, whether or not someone would need to go to detox, or someone would need to go through long-term rehabilitation or short-term rehabilitation, or whether they were going to go inpatient or outpatient, or whether they were could possibly just benefit from individual therapy. So currently, the United States is in the midst of an opiate addiction epidemic. Here we see in this infogram from Hazelden Betty Ford some of the statistics, including that 116 people die every day from opioid-related drug overdoses, that 15,469 deaths are attributed to heroin overdose, and 17,087 deaths are attributed to overdosing on commonly prescribed prescriptions. And then we see in terms of the economic costs, $504 billion.
So let's pause it there real quick and take a look at this YouTube video. This YouTube video is Senator Hassan doing some questioning somebody on the pharma's role in the opioid crisis. So let's play this.
I want to spend a little bit of time on one of the issues that I don't think we've touched on as much right now as it deserves. in your book, you chronicle the so-called Porter and Jick letter, which was
Yes.
a 1980 letter to the editor of the New England Journal of Medicine that was completely misinterpreted and used by prescription opioid makers to claim that their products are, quote, virtually non-addictive.
Yeah.
Doctors also wrongly relied on the letter as scientific evidence that addiction is rare when using opioids. It's astounding that one paragraph jotted down in 1980 helped fuel the horrible epidemic that we are seeing today. Your book outlines how drug companies have played a big role here and how some of them have misled patients, providers, and public officials about the addictive nature of their products. Can you give us a brief overview of the role of the pharmaceutical industry in creating the misconceptions about the Porter and Jick letter?
Brief.
You got a minute and 45 seconds.
A minute and 45 seconds. Well, I think the evidence shows it was pivotal in all this. This starts really with pain specialists believing that we were poorly treating pain.
Yeah.
And we were.
Yeah.
We were. We were. This is a story of a lot of people doing what they thought was the right thing, but doing too much of it maybe, or turned out better. I don't believe that they would have had the megaphone that they came to have were it not for a lot of the money and the funding and the use of the selective use of their information by pharmaceutical companies. I think their money and influence was what really changed the tide. And then, of course, they were joined by certain institutions like the VA and JACO, the Hospital Accreditation Organization, Fifth Vital Sign, and all that kind of stuff. But I think they saw early on, and Purdue was one of these, that saw that they had tried a time-release opioid, right? MS-Contin, only for cancer patients. And it was a magnificent drug. Had they just kind of stuck right there, we'd have been applauding them.
Right.
Instead, what they saw was that the dying cancer patient market was pretty small.
Yeah.
And there was a much larger one called chronic pain, or just normal pain of Americans, basically. And they got on board. This was also, by the way, an important part of all this is that these years were involved the industry went through a Salesforce arms race where every company was hiring more and more and more and more sales reps. And these were not the older sales reps who were really more grounded. In fact, it's my impression talking with doctors who knew these older fellows, most of the guys, that these guys knew what they were doing, and they were not such a hard sell. They were more informational. And then you hire a bunch of young folks, a lot of very good-looking young folks to inundate. And so our pharmaceutical reps went from something like 35,000 to over 100,000 in about a 5-year period. All of that also is part of this story. And I have to say this, though. This is a complicated tale, and I wanted to not blink at the complications. I believe also we as Americans play a huge role in all this. Our desire to have quick end to pain,
Right.
to not be accountable for our own wellness.
I think that is fair. I am over time, and I see that. I thank you for this. I also just won't have a time for second round of questions, but I will say that in my state, the need for funding to support the grassroots efforts like our Safe Station programs and some of the things our law enforcement is doing and treatment is critical. And I would look forward to talking with you more about that. Thank you, Mr. Chair.
Thank you.
So a very informative video there, and some remarks from somebody that some interesting things to say about that quote from that book in the 80s. So we're gonna go back to Margaret's presentation here, her PowerPoint, for a few more minutes.
Next, we continue on speaking about behavioral addictions, also known as process addictions, defined as syndromes analogous to substance addiction, but with a behavioral focus other than ingestion of a psychoactive substance. There is a high crossover of substance use disorder in behavioral addictions, as we see here in this table, indicating lifetime estimates of substance use disorder with these other behavioral addictions, including gambling, kleptomania, skin picking, compulsive sexual behavior, internet addiction, and compulsive buying. So again, the DSM-5 includes 2 behavioral addictions. One is gambling, and then in the conditions for further study, which is section 3 of the DSM, we see internet gaming disorder. Here is the DSM-5 listing for gambling disorder. We see the criteria is very similar to the criteria for substance use disorder, including needing to gamble with increasing amounts of money to achieve the same effect, restless or irritability when attempting to cut down or stop gambling, repeated unsuccessful efforts to control, cut back, or stop, preoccupation, using when feeling distressed, and we see additional criteria there. There's some gambling resources. The American Counseling Association has a practice brief. SAMHSA has a gambling toolkit. And there's the 12-step program, Gamblers Anonymous, as well as Gam-Anon, which is also a 12-step program for family members and concerned others. Here we see the listing for internet gaming disorder, which again is in section 3 under conditions for further study. What that means is there was just not enough research to substantiate it being a full-fledged disorder in the DSM-5, but it's a call for research on this disorder along those lines to see if it does qualify as a full-fledged disorder, which will be evaluated at the next revision of the DSM. There's been a lot of increased attention these days on screen use addiction, not just limited to internet gaming, but screening use of all time. Okay, we see here a list of other behaviors that are often spoken of in terms of addiction. They pertain to sex, love addiction, screen use addiction, shopping, work, exercise, and food addiction. Here are just some resources for assessment of some of these disorders.
So let's take a look at that sex addiction video. This is about 3.5 minutes.
One of the things that you probably see out there in the media and in the literature is, does sex addiction really exist? So there's a lot of controversy out there about this. And really part of that is because we don't have an actual diagnosis right now. As many of you know, it's not in the DSM. And it actually, if you look at the history of the DSM, it used to be. In the DSM-3R, there was a category called non-paraphilic sexual addiction. There was a lot of controversy around that, and it was actually pulled out of the DSM. Part of that, there was some concern amongst the sex offender treatment community that it might be used to get sex offenders kind of off the hook, sort of like the insanity plea or something like that, and it would be used in court situations. So really it was pulled, and right now we don't have a diagnosis, which has just left the field bereft with a lot of controversy. If you look to the literature, the most common terms are sexually compulsive, sexually addictive, impulsive, and hypersexual behavior disorder. Now, one of the things that's very interesting is there's many authors that have conceptualized these different constructs, and really, if you look at how they conceptualize them and the criteria, they're almost exactly the same. Now, the addiction criteria are a little bit different in that it incorporates the ideas of tolerance, which is like you need more and more porn, for example, to get the same effect, and also withdrawal, which is that there's some distress when you can't access your behavior. So that's what sets the addictive model apart from the others. But right now, unfortunately, it's not in the DSM. So I'm just going to give just a general definition that's really easy to understand. It's sex addiction is a pathological relationship to a mood-altering experience that's sexual in nature that, despite adverse consequences, the individual continues to engage in. Now, this definition is very straightforward. It's a little different than what the American Society of Addiction Medicine has out there. I won't read this whole thing to you, but it took 80 neuroscientists in 4 years to come up with their definition of addiction. And this came out in 2012. And the thing I want to point out to you is that ASAM has, for the, in these past recent years, really acknowledged the behavioral addictions as addictions. So as you see in their definitions, they include food, sex, alcohol, and other drugs, other behaviors. So there is, in particular in the American Society of Addiction Medicine, more and more acceptance of the concept of behavioral addictions and looking at sex and porn as an addictive process. So it's very similar to chemical dependency. It can be used to numb feelings, escape the painful parts of life. It can be very mood altering, become central to life, feel like the most important thing.
And once again, that that will be on our reference page if you'd like to go back and take a look at that.
So as we conclude this section of the webinar, I would just like to point out this study by Grant, Potenza, Weinstein,
And Gorlick.
and can't see the name of that author as I'm recording. You have it in the reference list. Growing evidence indicates behavioral addictions resemble substance addictions in many domains, including the natural history. They are chronic. There's a relapsing course with higher incidence in adolescents and young adults, having to do with phenomenology, so the subjective craving, intoxication, and withdrawal, the presence of tolerance and comorbidity, the overlapping genetic contribution, neurobiological mechanisms with roles in several systems, including glutamatergic, opioidergic, serotonergic, and dopamine mesolimbic systems. And the response to treatment is similar. So this concludes this portion of the webinar. Thank you for joining us.
Okay, so now it is time for our quiz for review. So I'm going to ask the questions, and because this is not interactive, I will just give it a pause for a few minutes or a few seconds so that you can either pause the video and go back and search for the answer, or you can just give it your best guess. So here we go. Quiz question number 1. The war on drugs was generally effective or ineffective? So we heard from our video that the answer to that question, question number 1, the war on drugs was generally ineffective. There was a lot of consequences that were horrible consequences as a result of the war on drugs that we're still experiencing as a society and as a nation. Question number 2, in the psychodynamic model, when does substance abuse resolve or become unnecessary? All right, the answer to number 2, in the psychodynamic model, when does substance abuse resolve or become unnecessary? When the underlying problem is resolved. In this model, drug use was a maladaptive coping strategy, so once the problem is resolved, there should be no additional needs for maladaptive coping strategies. The problem, however, is what if one thinks that the underlying problem has been addressed when in reality it has not? Then it is most certainly going to cause that individual to return to that state of abusing substances, which is one of the greatest things about the abstinence model is that even if the underlying problem was or was not addressed, making the decision to never use substances again will not be much of an issue for one's life. Question number 3, the integrated model does what? As Margaret stated, the integrated model says that there is truth to all of the previous models, psychodynamic, the sociocultural, behavioral models, biological models, etc. And that single model explanations are too simplistic to explain such a complex issue as addiction. Adapting this particular model is much less polarizing with regards to trying to explain the root of the addiction or pathologize, but rather look for how to address the problem. The integrated approach is more collaborative, evidence-based, multidisciplinary, and holistic. Question number 4, true or false? The DSM has undergone many changes over the years with regards to addiction, alcoholism, and substance abuse. The most notable change is that the classification has went from being lumped with sociopathic tendencies or considered a moral deficiency to a single diagnosis with severity categories. And the answer to this one, of course, is true. With stigma being lifted and more people feeling the effect of addiction, either directly or indirectly, society is much more accepting of individuals with substance use disorders. So one example of this single diagnosis with severity is 303.90, alcohol use disorder, or AUD, mild, moderate, or severe, or 304.40, amphetamine use disorder, mild, moderate, or severe. For those of you in the field, you may remember previous editions of the DSM where dependence and abuse were their own subtypes with their own diagnosis codes. Here is what the DSM-5 looks like. If you have not seen it before, it's quite a thick text. And here it is on Amazon's webpage. This particular one is $120.96, which is much less than it was when it first came out in 2013. And I'm highlighting the ISBN number if you would like to pause the video or simply write it down or search. Question number 5, true or false? Our final question. The economic cost of the opioid epidemic is $504 billion. Yes, that answer is true. Regardless of your political leanings, the opioid epidemic is a bipartisan issue that currently is not getting any better. It's only getting worse. It's very difficult finding someone who has not been affected either directly or indirectly by this epidemic. That concludes our webinar today. We hope you enjoyed it, found the information useful, and or learned something from it. I'm going to pull up the reference pages now so that you can browse the various pages and sources that we referenced. There is the first reference page. And there is the second reference page. You're more than welcome to pause the recording if you'd like to take a closer look at the references or write something down. Once again, since this is not a live webinar, but instead one that was pre-recorded, please feel free to post your questions or comments in the section below. Thank you so much for joining us. Enjoy the rest of your day.